would be working within hospice palliative care. It is peer reviewed, which is a very important part that we'll get to a little bit longer or a little bit later. And then I've added a couple of scores in there. So we are going to talk about different aspects all the way along, but every journal has a couple of ratings that if you think about it, same as going on to Google and giving a review of something, they have a rating system. So one of the things that you can look at is the impact factor. And this impact factor is something that is assigned to every journal. I went and did a little digging, and because it gives you this great number of 2.238, but what does that mean? So when you look deeper, an impact factor, 1 is average, 3 is good, 10 is the most amazing journal you've ever heard of your entire life. So when I was doing the research, landing in between 2 and 3 actually means that it is above average and closing in on good. So that is another good stepping stone in what we're looking for. The site score is another newer tool that you're seeing in some of the journals, and that is has a little bit of math to it, but it looks at the number of times that their articles are cited in the last 5 years, divided by the number of publications. So on average, how often would somebody use an article within this journal to cite for a source? And the answer is about 3.2 times. So it's another good rating that you can see that just gives you a bit of information into the journal. So one of the other things we're going to look at when we look at the journal today, specifically, we're going to look at the authors. And I think those of you that have worked in palliative care for a while may understand why. So in this journal article, they had 3 main authors that were there, and they very carefully listed at the bottom some credentials about all of them. But one name really sticks out, and that would be of Harvey Chochinov. And we're going to talk about the significance, but he is a very well-known part of our palliative care world. So he was the lead researcher with the team that really put together the dignity model and dignity therapy. So off to the left there, I have the logo and the website for the Dignity in Care, where you can find a whole bunch of information about Harvey Chochinov. It goes right through. You can see that his accolades keep going on, in that he has lots of high different appointments. The other thing, when you look down, the awards and publications, they just keep coming for Mr. Chochinov, for Dr. Chochinov. You can see that he is very busy within. And if you do go back and you look through the website, you can actually see that he has even more recent publications, and it's a continued endeavor for him and something that he is very committed to. Just want to point out, he's also the co-editor of several of the Psychiatry and Palliative Care Medicine and the Journal of Palliative and Supportive Care. So he has a very strong standing. So when I looked at this article and I looked at the author, I felt that there was enough there that it would be worthwhile for us to look at. So this is the article that we're going to break down just a little bit more, and it's about death, dying, and dignity in the time of the COVID-19 pandemic. So a few things to mention about this. First and foremost, this is an editorial. So it is an opinion, and we want to explain a little bit more as we lead into why did we choose this article. So I think it's fair to say that COVID-19 has had a tremendous impact on everyone throughout the world, irregardless of your role. And there is a lot of information out there about COVID-19. Some of it's correct. Some of it was correct at the time and is now not correct. And some of it never was correct or never supported or validated. But it's all out there. So the article we're going to discuss is the guest editorial. It's not a study per se, but an opinion based on all the information that was available to them. From our review of the journal and the lead author, we determined that the information and opinion is relevant to do further discussion. So we want to just acknowledge that those working within healthcare as well as other settings, have had to consider a lot of the issues that were raised. If you haven't had an opportunity to read the article yet, it is a free source article, so you can find it by Googling any of the information that's on the screen, including the DOI, which is an easy way to locate it. And we want to look at it deeper because it talks about how do you balance doing our job and doing it well against the health of ourselves and our families. The need to ensure that adequate PPE has taken away some of those personal interactions and that closeness that we've really been able to share with our patients. And I always go back to the mileage that I've gotten over the years working with those in hospice palliative care of a well-timed smile. And now with the PPE that we wear, we've lost that ability to be able to do that. So adding into that, the idea of the visitors restrictions and how that weighs on patients and families, and as well as acknowledging those that have to enforce those rules and how that fear and isolation that we witness can add to our burden. So this article really pushes us to view all of this from different angles and consider an approach that the author feels would promote dignity for those who are dying or those trying to come to terms of what it would mean to die during the COVID-19 pandemic. So it has a lot of different ways that we look at it. So we looked at that and we looked at it and thought, well, why? Well, this is a topic that we are saturated with. However, this isn't just telling us there's a problem. It's acknowledging an issue and offering a potential solution or a potential approach that might be able to help. And I think that's why it really drew me in, because I've read so many news articles that's going about the issues that we face, but this approached it from a little different way. And it does have very wide-reaching effect. And when we look at the data, we're going to look at some of the data that really shows why this is an important topic for us to look at. The other thing, if you've been lucky enough to take fundamentals or CAPC with us, this article really builds on known concepts that we discuss within both of those courses and that of the dignity therapy. And we will talk more about that as we go through. So first of all, we want to look at the data. Everybody loves looking at the data. So when we're talking about an article, what are they using to base their opinion on? And the first part that they talk about is to acknowledge that people are continuing to die. So when this article was actually published, it was published in April. So the pandemic had started and was starting to pick up steam, but they used the fact that, although it has claimed, lives, 60,000 people have died in Canada since the outbreak had been declared, but only a fraction of those had died from COVID. People are still dying. And they use that as one of the reasons to support their claim that we need to look at this approach. The other thing is they look at some systematic reviews. So they take a look at what is out there and they refer back to a review that shows that hospitalized patients placed in isolation for medical reasons are more likely to experience depression, anxiety, anger, and loss of self-esteem. Healthcare providers actually spend less time with them, which can impact patient safety. And there's actually an 8-fold difference in adverse events. So some very important data to use to help support their point again. So the next way we look at it is they talk about, well, what other relevant research is out there? So when I went through and looked, they make reference to, in the part where they're speaking about the impact on family of not being able to get that closure. And they look at a report that came out of after SARS. So the SARS Commission report noted that, and they have a direct quote saying, those left behind had no opportunity to confront the reality of death and to honor the life of the deceased. So they go on to say, funeral rites must obviously carry lower priority than the needs to contain the public health threat. So they actually acknowledge that within the SARS report. So they again are using that to bring up and support their opinion. The next part of research they look at is a study out of China, which obviously this is an evolving thing. This was coming out of China based on COVID-19. So one of the early areas that was able to produce data, and it talked about doctors and nurses working with COVID-19 patients. And they were reporting exhaustion due to the heavy workload and the protective gear and a large level of fear. And not only fear of being infected themselves, but infecting someone else. And they were worried about the sense of being fully responsible for those patients' well-being. So they did take some time to really look at that. Then he also likes to refer and draw on his own research, and including his previous research into dignity therapy. And he really takes the time to explain to us why he feels this approach is supported in data. And he explains to us that his research has shown that a lack of social supports, symptom distress, and not feeling valued or respected can undermine a dying patient's sense of dignity. And his belief and what the research showed was that those who are isolated or avoided are especially vulnerable. And they're inclined to feel that they may not only have an issue, but they may be the issue. So it was a really strong point. And what Kate's going to talk to you about a little bit further when we get in is the research into using some validated tools to help to promote this dignity within patients. So Kate will expand a little bit more on that a little bit later in our presentation. Computer wants to run, or it doesn't want to go at all, sorry. So he acknowledges the struggle within the article. And this is a direct quote from the article where they talk about the effect on the healthcare worker. So the pandemic has seen healthcare providers being forced to engage in what some have called impoverished care, where the obligation toward patient care must be weighed against the obligation for self-protection and that of one's family. So it talks about the internal debate. And I think that that is very important to think about and to look at when we're doing that. So this really leads us into what he wants us to think about and what he would like us to look at. And that is the ABCD of dignity conserving care. So if you've taken CAPC or fundamentals, you may have gotten one of these handy dandy little cards, which I know is not best for me to show you this way, but this is what it looks like. Also going back to, if you Google the Dignity in Care website, you can see those same kind of informations. But it really does give us a bit of information and talk about how you can use that ABCD and going forward. So just to put it in context for Kate's discussion, when we're talking this through, is they really want to look at this ABCD and what does that truly mean. And so A obviously stands for attitude, and it really, they said within their research, has shown that dying patients perceive themselves to be seen based on how the attitude of those caring for them. So a provider's attitude has a tremendous impact on what people feel about themselves as they approach the end of their life. So B is for behavior, and they always talk about this within his article about kindness and respect. And it can begin with just simply taking a seat. So he again uses research to make his point of referring to a randomized controlled trial that simply said standing or sitting is what they were looking at. And by sitting, you can have a much better rapport with patients, and patients felt that their provider was more present by that simple act of sitting and not standing. The C in the ABCs, D, is talking about compassion. And that's talking about looking at what can we do to help decrease the suffering of others. And they go on to be very clear to make sure that you understand that it doesn't necessarily have to be a heroic act. It can be as simple as getting a glass of water, finding the correct television channel if they're fans of the Blue Jays, that you take the time to find that for them, or simply listening is a way to fulfill that. And the D, of course, is the dialogue. It talks about having that good communication with patients and how important that truly is. So in conclusion, looking at the whole of the article, they absolutely acknowledge the need for further research. Because of when this opinion was given, and the fact that Dr. Chochinov certainly does love research, I'm not surprised that he feels that there could be more that we could do to look at how could this help given the situation that we're in right now. So people are still dying. This is not news to anybody who's here on this call, who works within this group, but it is a fact that we need to understand that people are not just dying from COVID, they're dying during it. And what can we do? So we need to consider how the pandemic is impacting those that are approaching death, how it's approaching the families that are unable to maintain that close contact, and how is it affecting those dedicated healthcare providers that are still doing their best to provide that optimal hospice palliative care given the circumstances. So what I liked about this article, and what I think it really does, is gives us another tool for our toolkit, gives us another way to look at things, gives us an opportunity to take that knowledge and translate it into action. So before I hand it over to Kate, I just want to say this is my thought on what we're looking at. And we spent a lot of time trying to find a way, because we know we can't tell people just not to worry. That doesn't work. But what the focus of the quote is that we need to focus our energy on things we can control. And what we can control, we have to go forward with. So that is our attitude, that is our effort, and that is our focus. Those are what we can control. We can't control COVID, but we can control our approach. So I am going to ask Kate if she can pause the recording. And I'm going to give her control.
Hello, welcome to the case study portion of our nursing forum. We had a discussion as a group. We had a great cross-sectoral representation, and we had lots of participation in looking at the following slides and case studies. So we just wanted to take an opportunity to share that with you, because we don't record that discussion, so that people can have really in-depth conversations about how this actually applies in their work. What we started out with was, I put this screen up and asked, what does dignity and care mean to you? Wanted to get people's brains thinking about, what does that actually mean in my nursing practice? All of these terms are things that come out of the dignity and care work that's been done by Chochinov. But what really resonates in your own practice as things that you feel that maybe you're really good at, and maybe there's some things in there that you think, wow, I really need to work on that a little bit more. So we took a couple minutes to look at that before we jumped into our case study, and we talked about Maggie. Now, Maggie was based on a number of different people that I met while actually doing bedside care during COVID. And I pulled a lot of those things into this story to really try to build a picture of an actual person that we might see in our practice in this time. So Maggie is an 86-year-old cisgendered woman who was admitted to the palliative care unit of a small town hospital at the end of August for end-of-life care. She has had a lengthy illness with a primary diagnosis of lung cancer, which has now metastasized to her liver. She has a daughter who lives in town, a son who lives in Sweden with his partner, and 3 adult grandchildren. Her husband died suddenly 7 years ago of hemorrhagic stroke. She worked as a librarian at the local library for 30 years and has since spent her time traveling, hiking, and knitting. When she comes to us, her PBS is 40%. She can mobilize with minimal assistance to and from the bathroom, but she still needs help with her personal care, dressing, and getting up from the toilet. Maggie watches multiple 24-hour-a-day news channels throughout the day. She finds she can't concentrate enough to read, and she's bored, and she's missing her family. Maybe because of that, she's terrified of contracting COVID-19 while she's in the hospital. Her daughter Helen is her only visitor. Maggie is nervous about her visiting because Helen is an administrator in a long-term care home, and she's feeling pressured by her colleagues not to visit her mother in the hospital. So the first thing that we talked about as a group is we asked, what are some of the potential dignity issues that you worry about when you hear Maggie's story? Some of the things that were identified are worrying about She's had a lengthy illness and now she's in the hospital. How is that affecting her emotionally? Worries about her isolation from her family, her daughter specifically, and then being isolated from her son who lives far away and her grandchildren who she can't go and visit anymore. People had worries about her watching 24-hour-a-day news channels. How is that impacting her and her feelings of isolation and also her confidence in the care team? People had worries about what kind of isolation is she experiencing being in the hospital with care providers who are having to glove and gown and mask every time they come in to see her. How is that increasing her isolation? Because, well, yes, absolutely, we would want to, as healthcare providers, ensure that we are still checking on people and having the same interactions with them as we were before. Let's be perfectly frank. It's a lot harder to go in and have a quick check-in on somebody and see how they're doing and just drop by and say hi when you have to glove and gown and mask. And that can be a barrier to increased interactions with patients. The next thing we thought about is in a dignity-conserving approach. What could you do next? What would you do next in this case? Some of the things that people identified were looking at, could we ask the patient dignity question? We talked about, will she have any visitors with her daughter in the role that she's in, and how could we find alternative ways for her family and her to connect? Could we use Zoom? Could we set up regular phone calls? How could we allow her opportunities to make as many of her own choices as possible and give her power back? Because when she's been brought into the hospital at this time, she may be feeling a loss of control, which often translates into a loss of dignity over her own care. So we then took a minute to look at the patient dignity question that Chochinov references in the article. And I really love this question. What do we need to know about you as a person to give you the best care possible? And I had everybody think about, what would it feel like if every time you went in to see a new healthcare provider, whether it was a new doctor, or you're going into physio, or you were maybe even in the hospital and having somebody come in to see you, having the nurse come in and you're meeting your nurse of the day that morning. What do I need to know about you as a person to give you the best care possible? How would you feel if somebody asked you about that, rather than starting right away in with their assessment and asking you about your disease and asking you about, do you have any pain? And please rate it from 0 to 10 and what makes it better and what makes it worse? What would that feel like? And then I want you to think about, what would it be like if I actually asked my patients that, or my clients or my residents? What would it be like if, instead of starting my assessment every morning, I went in and asked new people, what do I need to know about you to give you the best care possible? Or what do I need to know about your day today? If this is someone you see regularly, what do I need to know about your day today so that I can meet you where you're at and we can work together on a care plan for today? It's a really easy question to bring into your practice. Now, the other thing that was referenced in the article is the This Is Me questionnaire. These are the questions that come out of it. I will be completely honest, I had a bit of a time trying to find it. It's actually buried in one of Chochinov's, I think it's a master's student research, but it is a validated tool and asks some really fantastic questions. We won't go through all of them, but things like, are there specific accomplishments or roles that you would like us to be aware of? Do you have particular worries or concerns that you would like us to be aware of? Sometimes we don't know that, or we assume, they're worried that they're at end of life. They're worried about their nausea and their pain. And it turns out that they have worries that have nothing to do with anything they're experiencing. They're worried about their kids. They're worried about things that are happening outside of their hospital bed or their long-term care bed. They're worried about all sorts of other things, and we might not know that if we don't ask them. It doesn't seem to be particularly widely used in this model, but what I do see and what we heard from the participants in our case study review tonight is that we see different versions of this. In some long-term care homes, they have a piece of, they have a sheet that goes on the wall where they ask very similar questions about, who is this person? What do we need to know about them to give them care? What are some great things that they wanted to share with the care team? And how does that stay with them as maybe they lose the ability to connect with us verbally? It gives us an idea of who that person is. I know in some of the palliative care settings that I've worked in at the bedside, they have a board that, it comes with a whiteboard marker, and the patient and the family or the care team can fill that out with, what did you do for work? What's a fun fact your family may not know about you that you want to share? There's lots of ways to look at getting to know the person as a person and who they are, and not their diagnosis, not how long they've been here, not their PPS, not their expected trajectory, but who they are as a person, and give us access to them in a different way than we may with our general assessment questions and our admission paperwork and all of that other stuff. So we then assumed that we applied some of that to Maggie. Maggie shares that as an only child growing up, she was often left alone for long periods of time and feels this contributed heavily to her suffering from recurrent episodes of depression as an adult. She now fears that by the time she dies, visitors may be prohibited again with a second wave. The hospital's palliative care unit allows 1 visitor per day per patient until the patient's PPS drops to 10%, and then allows 2 visitors per day. Since retirement, she had enjoyed bi-weekly lunches with her daughter in town and yearly visits with her grandchildren in Sweden. She is worried about the stress on her children, for her daughter working in long-term care and her son deciding whether or not he will come visit her, as that means serving 2 14-day isolation periods and being away from his own children during this pandemic. Thinking about some of these very real fears for Maggie and relating them back to the concerns that Chochinov has about isolation, about families potentially experiencing complicated grief because they can't go through the same rituals and routines that they did that we would have prior to COVID. Funerals look different. People can't start that grief and bereavement process in the same way that they have historically. They don't have the same supports that they had in place. We can kind of see how for this family, and for a lot of families like them, as I said, these are based on real things that people experienced during the pandemic. Because as Sarah mentioned, people are still dying, not of COVID, but of all the other things that Canadians are living with and dying with in 2020. So I want you to think about what that would be like for a patient, for a family to be experiencing those things, and how you would meet them as a care provider. We talked about how this information would guide our next steps. Again, we talked about how could we help Maggie and her family connect in different ways. What are some other different therapies that we could bring in? One really great suggestion was, how could we help Maggie do some legacy work? Somebody also suggested we could help her with writing some letters. We could suggest audiobooks to her. She was a librarian. She was struggling with being able to pay attention to reading books, but she can watch TV. Could she listen to some of her favorite books on tape, or probably more likely on a phone or on an iPad? We talked about a few different ways that we could meet Maggie where she's at with this information. We could ask her more questions about what she needs. What would her ideal visiting situation look like, and how can we get her as close to that as possible with the visitor restrictions we have in place? We also asked the question of, how do you think the PDQ, or the patient dignity question, and the time questionnaire would be valuable in your practice? I want to encourage you and push you to think about, how could I incorporate those in my practice if I'm not already doing so? And that may look like a systemic change. That may look like, how do we actually get everybody in our care to do the time inventory? Or how do we look at incorporating that into all of our care providers? It can also be as simple as, how am I going to incorporate the patient dignity question into my work tomorrow? I'm going to try and remember to ask at least 3 of my residents, I've known you for a while, but what do I really need to know about you to give you the best care possible? Sorry, folks, my dog just decided she needed to be involved, and she would like to know about the care that I'm going to give her in a little bit as we wrap up. We ended with this quotation. So grateful for all of you who have taken the opportunity to either come to Journal Club and then look at the recording to learn some more information, or you've found this through other means and you're trying to better and deepen your palliative care practice in providing a dignity conserving approach during the COVID pandemic. We recognize this is a challenging time for all of us, and our ways to connect and our ability to connect has really changed drastically in the last 6 months. We commend everyone here for continuing to try, and I'm sure actually succeeding in delivering excellent evidence-informed palliative care. This resonated with me because it's not all about how can we implement this in a big way. But as Brene Brown says in this quote, empathy has no script. There is no right way or wrong way to do it. It is simply listening, holding space, withholding judgment, emotionally connecting and communicating that incredibly healing message of you are not alone. So I will leave you all with that wonderful thought, and also take a moment to encourage you to check out our next journal club or nursing education forum, where we will do another journal article review. We will look at how do we know that this is a good article in palliative sedation, and then we're going to talk about palliative sedation through a case study and actually apply that knowledge into practice. That will be posted. If you're not able to join us live, which I hope you can, that will be posted on this YouTube channel, the Hope Palliative Care Nursing Education Forum. And if you have any questions in the meantime, please don't hesitate to reach out either to myself or to Sarah. Our email addresses are here, and we look forward to hearing from you. Thanks again for joining us, and have a great day.